Good morning. It is still morning, correct? Yes, okay, good. Everyone's still there? Ni hao? Okay. So I'm really incredibly pleased to be here and honored, and thank you to the distinguished panel for this opportunity. In my role at Susan G. Komen, which is a large breast cancer foundation based in the U.S., I had the great privilege of leading an education outreach program in China. And we spent many years working in communities in Beijing, Shanghai, Jiangsu, Guangzhou, and Zhongshan. So it is a wonderful pleasure to be here with all of you today. The first panel that we heard earlier really talked about the systemic issues facing us as clinical trialists and patients trying to access care. But I think it's wonderful that we're now moving toward hearing the voices of the ultimate beneficiaries of that work, and that is our patients. And we're going to talk today about patient-centricity in clinical trials, and what exactly does that mean? So I want to ask the audience a question, if you're willing to share. How many of you are actually living with cancers or survivors of cancers, or having helped someone through a diagnosis of cancer? It's all of us. This is really personal, and I believe that it's the personal passion that has driven all of us collectively and globally. And when I say us, I mean patients, providers, policymakers, persons working in industry. We all have collectively worked together to achieve great progress through research and through clinical trials that have been driving our understanding of cancers and creating precision medicine. I'm excited for the session later on this afternoon where we're going to hear more of the fruits of those scientific labors. But none of our progress would have been possible without patients participating in these clinical trials. The evidence that we heard also today from Dr. Norton, not only do patients who are on clinical trials benefit, but patients who are seen by physicians who conduct clinical trials also do better. The standard of care often is higher. So what seems to be an obvious choice of care for millions of patients diagnosed with cancers across the world is not very obvious, and you heard the statistics. 95% of patients or more are not engaged in clinical trials at all. So we have a lot of work to do, and I think that work is better done by global cooperation, which is what we're here to talk about today. We have a lot of barriers to overcome, and you all know the list. We know that patients aren't asked to participate. We know that the infrastructure that we heard about earlier is not set up for success for our physicians who are conducting clinical trials. We know the social determinants of health stand in the way of a lot of people accessing it, and we can go on and on. But our panel today is here to say that if we look at these problems through the lens of patient centricity, we can find some solutions. And so I am very thrilled today to be joined by an exceptional group of experts. There are those who have the lived experience of cancers, but those who are also working to ensure that people live through their experience of cancers. And for some of them, they serve in both roles. So I'm going to do some quick introductions and let us dive in, because we have a lot to talk about in a short time, and we want to leave lots of time for the audience to ask questions. So I'll start first by welcoming Terry Conneran to the stage, who is a lung cancer survivor and founder and director of KRAS Kickers. And she will show you her amazing socks. If you ask her, she will. She's taking this literally. Welcome, Terry. You can take a seat. Dr. Simon Powell. Dr. Simon Powell, who is the chairman of the Department of Radiation Oncology at the wonderful Memorial Sloan Kettering Cancer Center here in the great city of New York. Welcome. Orville Schell from right here at the Asia Society, where he serves as the Arthur Ross Director of the Center on U.S.-China Relations, and he's also a former professor and dean at the University of California, Berkeley Graduate School of Journalism. So I assume, sir, we are all on the record here today. Is that correct? Okay. Please join us. Please join us. We also have Lillian Lee, who is the Membership and Advocacy Chair, a board member of TOGA, which is the Thoracic Oncology Group of Australasia in Australia. She also, in her regular life, is a lawyer and also living with lung cancer. Welcome. Okay, and last but not least, the person who asked me to give the shortest introduction possible, because his list of credentials is very long, is my friend and colleague, Dr. Otis Brawley, who is the Professor of Oncology at the Johns Hopkins University School of Medicine, the 39th Bloomberg Distinguished Professor at Johns Hopkins, and he wants you all to know that he is also an epidemiologist, a career that has come into the public consciousness thanks to COVID. Dr. Brawley, he gave me that joke, and so thank you very much for that. So we're going to dive right in, and I want to start, again, with the ultimate beneficiary of this work, and the person I think that is best suited to describe what patient centricity is, and that's Lillian Lee. So can we start with your story, please?
Thank you, Victoria, and thank you so much to Bob Lee, MSK, and CTONG for having me here today. I'm literally a beneficiary of clinical trial, and I'm here today because of a clinical trial. I'll start from the beginning. It was my 34th birthday. I was in my dream job as a social justice lawyer. I had a 3-year-old and we're looking to grow our family. And then 6 days later, I was diagnosed with lung cancer, stage 4, non-small cell lung cancer. I had a wonderful medical team who actually is here today. I was feeling, hopeful, because after a period of waiting, I found out that I had a rare mutation. It was ROS1, and I was able to start my first targeted therapy. Unfortunately, after months of dose reduction to try and manage a toxicity, I wasn't able to continue with that medication. And so I was then referred to Melbourne, which is an hour away. I'm from Sydney, Australia. It was an hour flight away to participate in the clinical trial, phase 1. I learnt a lot about clinical trial through not just my medical oncologist and the doctors in my family, but also through patients online. And doing a lot of reading and research about whether it was possible for me to fly across the border of our state to another place to participate in a clinical trial with a young child and a job. It was initially every week of flying to Melbourne, and then every 3 weeks. And I would be there, it would take probably about 4 to 6 hours from door to door of traveling, and sometimes just for the day, just for one blood test and one conversation with my oncologist to participate in that clinical trial. But for my life, I would do it. I had been on that trial until I was kicked out of it because they just couldn't continue myself on the trial and was able to give me that drug on a compassionate access. And so for the last 8.5 years, I've been taking that targeted therapy, and I've been feeling really well, and I'm really pleased to be here today.
You shared them. Where's the moderator? Can you work the microphone? Thank you, Dr. Brawley. Okay. He's also a great assistant, in addition to being a great epidemiologist. So Lillian touched on a number of really important things that we need to think about if we want to achieve true patient centricity. You said the word ROS1, which is really interesting and very sophisticated, that a patient knows their molecular profile. I can speak from the perspective of Susan G. Komen. We have 50,000 people who call our helpline. About 75% of them could not answer the question, what type of breast cancer do you have? pretty amazing, right? So that knowledge that you had, but also your experience of trying to live life around your breast cancer treatment, the challenges of transportation, childcare, your career. So a lot of things we need to think about in terms of clinical trial design. We're going to get back to the design question in a minute, but I want to ask Terry to jump in because your experience was a little different. Clinical trials wasn't on the lips of your treating physician at the beginning, so let's share with everyone your story.
Okay. I'll keep the story succinct. 7 years ago, about this time of the year, I had a cold. Long story short, 2 days before Christmas, they found something through an X-ray, and it was pneumonia, and it inevitably led to lung cancer about a month later. It was stage 3 lung cancer, January 2017. I'm coming up on my 7-year survivor. I went through chemo. I went to my normal doctor. I didn't go to a cancer center. I went to my community center. I live in Charlotte, North Carolina, 3 kids. My youngest was a senior in college. She's about to graduate. And on my daughter's 25th birthday, my older daughter's birthday, they called to tell me it was stage 3 lung cancer. I went through treatment, chemo, standard of care, chemo, surgery. I thought I was good to go. But now I'm dealing with the survivorship and trying to wrap my brain around what's going on and what just happened to me and my body. So I get involved with lung cancer support groups and got involved with a bunch of cancer, like exercise clubs and things, and started hearing about different sorts of information that I needed and different opportunities and different types of doctors I had no idea even existed. Last time I really dealt with cancer was when my mom died from it in 1992. The world has changed, but I didn't know that. And so as I started hearing from these lung cancer support groups and things about biomarkers and different sorts of treatments and different sorts of doctors and what have you, you walk into a lung cancer room with a room full of survivors, people in treatment, whatever word you choose, and they break up around these biomarkers. They have EGFR people here and ALK people and ROS1 people. I want to know where my people are. So I'm asking my doctor, what am I? You know, kind of like that book that the kids read, you know, Mommy, what am I? What am I? So I'm asking my doctor, what am I? She says, well, you don't have anything. Nothing. No. Well, I was okay with that, and I'm getting more involved in really becoming educated and learning all the things I didn't know I needed to know because I just come from a business background. So I go through this. First recurrence happens. First recurrence happens about a year and a half in. 2019, I've had a total of 5 recurrences over the past 7 years. First recurrence, I'm like, okay, great, I'm gonna learn out what my biomarker is. No. Good news is they were able to ablate it and move on. A few months later, next recurrence. I've technically moved from a stage 3 to a stage 4 patient. We were able to radiate it, but I'm good to go. I kind of have a mission. I'm really like on fire now. It's like now I've learned enough to know I'm not going to hurt my doctor's opinion, hurt my doctor's feelings if I ask for a second opinion. It's not going to really upset the apple cart, and I'm not going to really piss people off. So I go out for a second opinion at a big cancer center. First thing the oncologist says to me is, well, you have KRAS G12D. I have what? So yeah, it was on your first report, your second report, and when we reran your report, you have this KRAS biomarker. Well, I knew that there were biomarkers because there was these different groups, and I didn't have a group that I belonged to. So, all right, great. I'm gonna go home, I'm gonna find my people, get connected, because I'm sure there's a bunch out there. I go online, undruggable. Whoa, this isn't just undruggable like Joe down the block says this. This is undruggable for the researchers. I'm kind of scared, but I'm okay because I have no disease. So this is the time to learn. I get connected through all the different lung cancer groups that I've been talking to over the past 3 years at this point, and I start recognizing some similarities. You know, I'm going to state the obvious. I'm a white middle-class woman. Here's a funny thing. My reporting was done initially from my community doctor. I was asking the right questions, and I didn't get the answers. What do people that don't have the testing, don't have those box ticked, getting and learning? So when I found this out, and then I come to find out this KRAS thing is also the most common cancer. It's not just in lung cancer. In fact, the KRAS G12D is most common in pancreatic cancer. this is not just a me problem. This is a world problem. It's 1 million people a year that have a KRAS cancer. So that really just led to starting a group, because I wanted my people too. And so we call it KRAS Kickers. Why? Because I want to kick cancer's KRAS. And most of us call it the KRAS Kickers. And I'm okay with it. You say whatever you want with it, but we're going to kick it and we're going to make a difference. Since this time, okay, what we've become is we're a global organization. We're a global patient empowerment group. Notice, I didn't say support group. There's those too. We're empowering. What we've done is we take KRAS and we use it as an acronym. It may be what we've got, but it doesn't have us. Knowledge plus research plus advocacy equals survivorship. And it takes all of us walking side by side doing it. And is it just socks because it's cute? No. The socks on here represent the most common places you see the KRAS oncogene. White represents lung. That's our ribbon color. Blue is colorectal, purple is pancreatic, and gray is the ever-feared brain. And we work together to kick cancer's KRAS. We are the KRAS Kickers. You'll see around. I left out there's some KRAS, some no KRAS hole stickers. The kicker stickers, what those represent, that's what I ran into, a KRAS hole. The KRAS hole was I had a diagnosis, but I didn't have the information. I needed my doctor's wisdom, but I needed to be able to access it. A KRAS hole is not only the people that you know, probably driving on the streets, but also it is any sort of thing that interferes. It's a gap, it's a barrier. Anything that interferes with that health, outcomes, literacy, or equity. And so how we need to do this is we need to keep working together. This global thing, we're one world, one planet, one problem. Good Lord. AI plus artificial intelligence plus real intelligence is going to make a difference. And so I am just delighted to be here. And thank you all for having me, because I think that if we take this energy, we put this passion together, we solve all these little hiccupy problems, we can make a difference.
So I have an important question for you, Terry. Are those socks available for a small donation at kraskickers.org? Okay. So
Yeah,
you want to
absolutely.
Get your socks?
We can hook you up. The kicker stickers are free, and we encourage you. There's a QR code to the website. If you want to stay in touch, please do that. One little shout out about the KRAS Kickers. Okay, we are all about clinical trials. We aren't funding them because we're little and tiny. And although we're in 89 countries, okay, we're not funding. There's great orgs that do that. Many of them represented here. So please do that.
You made an important point that your patient advocacy crosses borders. It's not just where you live that you're reaching out to. You're crossing borders to reach to patients, and that's something, Lillian, that you're also doing with your work. You shared a story with me about your work in Indonesia, and I wonder if you might share that with your international work through TOGA. I don't think I got the country right. Your international collaborations with patient groups.
Yes. With patient groups, so probably with Ross Wonders. Yes. So Ross One, again, we have a group, and a small group of 5 American Ross Wonders years ago came together and started a Facebook group, and that has now grown to over 500, maybe even up to 1,000 members around the world with ROS1 cancer. And we're really wanting to drive research because we're so rare. And unless we collaborate, international collaboration is so crucial for rare cancers. And yeah, is that what you mean?
That's what I meant, thank you. So let's continue the theme of international collaboration with Orville and talk about, we're here talking about healthcare, but we're also talking about how global collaboration can encourage diplomacy in a lot of different areas. And Orville, you have a lot of experience with this, and I'd love for you to share the work that you do and how it might be relevant, but also your perspective of how you can change the hearts and minds of individuals and getting involved in something greater than themselves.
Well, thank you, Victoria. I think a debt of gratitude is owed to Bob Lee and Chen Jing and Wei Long, for gathering us together. It's not only been interesting, but I think hopeful. And God knows, in this parlous world in which we live, a little hope is always a welcome thing. I'm a China specialist, but I'm also, of course, a human being. And that puts us all in the category of cancer. My mother and father died of cancer. My sister and brother died of cancer. My wife, who was Chinese, died of lung cancer. I've had my experiences. So here, indeed, is a true commons, that it's just a part of being a human being. As to China, as you all know, the relationship between the US and China, Australia and China, and many other countries in China has been extremely difficult. And we have searched for some way to put a floor under the downward spiral in the relationship, and it's been very hard. One of the areas I've worked in is climate change, because it's such an obvious common interest. And yet, it's been difficult because China's economy needs to keep going. That means coal, that means fossil fuels, et cetera, et cetera. When we get to cancer, though, we actually have really no impediment between our two countries collaborating except ourselves, and the ability to jump over some relatively low hurdles, which have been generated by sort of the geopolitical controversies that divide us. So I think this is an immensely hopeful area in which not only can the US and China find some common purpose, but perhaps also make their relationship a little less fraught. And indeed, all of us who have concerns about cancer, have had tangles with cancer, it is a way for us to look in a little more global sense of what would improve the ability of the world to deal with cancer. And so here is an immense opportunity, not without challenges, but it's great to see some Chinese colleagues here. It's great to see that this is on the screen, because I think of all the common interests we share, this is one of the most important and perhaps also one of the most easy to purpose to our good purposes.
Thank you. You said the word easy, and that's definitely what we need to strive to. You know, we have a common goal, a common enemy, but sometimes it's not that easy in practice, Dr. Powell. So I'd like to hear your perspective, you know, working in the field, supporting patients, designing and executing clinical trials. You know, what really is the reality? How far away are we from patient centricity, and what do we need to truly get there?
Yeah, I mean, as a physician in a clinic, I mean, patients want answers. They want answers, and they want them quickly. You know, I think picking up on a theme from earlier this morning, our role as physicians in the clinic is to design those trials so they're not massively cumbersome and burdensome, and they can be executed, you know, in a reasonable time frame to get a conclusion. So I'll just tell you a short example that I think illustrates that point, I hope, very nicely. So in lung cancer and also in breast cancer, patients with metastatic disease go on first-line treatments. They often do quite well initially, but then at some point they will progress. At that point of progression in lung cancer, especially if you progress only at a limited number of sites, we don't know necessarily what's the next best thing. You don't want to rattle through too many treatments too quickly. So we address this point by saying, well, we've got great tools in radiation oncology. We can treat 5 lesions, no problem. And the ability of radiotherapy to deliver those treatments today is very easy. I mean, the technology is way improved, you know, from 10 years ago and even bigger improved from 20 years ago in just in the technical delivery. So when you design a trial, you've got to make sure that it's going to be conclusive. And in general, you know, the randomized trial is still the gold standard. Randomized trials are tough, right? Because if you, as the doctor, think, is it going to be better? Which patient doesn't want the it could be better arm versus not? But again, I think if we as physicians publish single arm studies, it never has the traction. So we launched a trial for oligoprogressive metastatic disease, to give it its medical jargon, where we intervened. We set out to be 180 patients, 90 breast cancer, 90 lung cancer, and we randomized them to getting radiotherapy at the first signs of progression rather than the standard of care, which is only if you're symptomatic. We utilized our network. It's not quite our China collaboration yet. Maybe that will be the next way we do it. But we utilized our network, we utilized our alliance, and we recruited patients to this study in about 18 months. And after the analysis of the first, I think it was 110 patients, the separation of the curves was already large enough that the full accrual wasn't completed because there was clear separation of the arms. We did a bunch of scientific details which you can read about shortly, because this paper is coming out in The Lancet in 2 weeks. And I think it's a significant impact. It was a simple clinical trial design. It had a specific goal. It proved to be not difficult to recruit to for patients. And it's a nice, clean impact. Probably we will build on this by moving to a larger trial. So I think that's an example of using a collaborative infrastructure, a simple design, a simple execution, and luckily a what looks to be very encouraging outcome.
That's incredible. That's great news to hear. I want to get back to clinical trial design and the role that patients can play at the beginning of clinical trial design. But before we go there, I want to go to our last but not least panelist. So I introduced Dr. Brawley as the professor at Johns Hopkins, but he's also served many roles as a policymaker with the NIH, NCI, also with patient advocacy organization American Cancer Society as their chief medical officer. So you have a very unique perspective on this issue. So I want you to wear all of your hats at once.
Sure.
Which I know you can do.
Thank you, thank you, thank you. Again, I want to thank Bob Lee for organizing all of this. Before I begin, the epidemiology joke we were talking about, in 2020, before COVID, if I were on an airplane and somebody asked, what do you do? I say, I'm a cancer doc and an epidemiologist. They would zero in on the epidemiologist and show me their rash. Now I'm going to make all of you an epidemiologist for a second as I argue that Cure for Cancer needs to work on how to treat cancer better, as well as how to prevent cancer. And this goes back to the Larry Norton comment about we can do a lot more than we think. In the United States, real world numbers in 2019, among all college graduates in the United States, for every 100,000, 89 died from cancer. In the United States, in the same year, for all high school graduates or high school dropouts, 189 died per 100,000. So we're talking about a difference of 189 per 100,000 for the less educated versus 89 per 100,000 for college graduates. That means that if all the people in the United States, the 2/3 who do not have college degrees, got all the things, starting with risk reduction and prevention, appropriate screening, appropriate diagnosis, and appropriate treatment, a large proportion, 40% or more, of the cancer deaths in the United States today would simply go away. One of our problems in the United States of America is implementation of the science that we already have. When I say implementation of the science that I already have, 7% of black women and 3% of white women in metropolitan Atlanta who are diagnosed with localized curable breast cancer get no treatment in the first year. It's that simple. By the way, the research that told us that you cut the tumor off was done in 1896. And in 2023, 7% of black women and 3% of white women in one of the richest countries of the world don't get that within the first year. Now, I'm all about clinical trials, but we've got to take the results of those clinical trials and actually implement them and get them to the people. Now, clinical trials are actually incredibly important because, as Larry Norton said, it was actually Dick Wernicke and Arnie Kaluzny in the early 1990s who actually showed us that if a doctor puts 2 or 3% of his or her patients on clinical trials, they take better care of the other 97 or 98% compared to doctors who do not participate in clinical trials. And one can argue, do the clinical trials make for a better doctor, or are better doctors attracted to clinical trials? I would actually argue that it's both. Now, we do need diversity in clinical trials, and that diversity is not by race. That diversity is much more by things like socioeconomics and area of residence, as well as area of geographic origin. The one thing I disagree with my good friend Rick Pazder is race has very little to do with metabolism of drugs. Area of geographic origin is where it's at. I can take him to areas of Africa and show him people who we call black who are very genetically different from people who we call black in other areas of Africa, both in terms of their risk for prostate cancer and how they metabolize various drugs. So we need to get rid of the race thing and start talking about area of geographic origin. We also need to talk about comorbidity. Many of our clinical trials require someone who happens to have cancer but is healthy enough to be an Olympic athlete. People who have beer bellies or people who have a little hypertension or diabetes are frequently excluded from clinical trials, which is unfortunate. But we also have to be very careful. I was involved with the development of the drug Taxol, which is one of the most commonly used drugs today. I can tell you in the late 1980s and early 1990s, Taxol development was delayed for nearly 3 years. That is, people in the world were unable to get Taxol for nearly 3 years outside of Bethesda, Maryland, because we gave Taxol to somebody who we shouldn't have, and they had a bad reaction, and it led to a series of investigations and so forth. So we do have to be careful and have some criteria for entry into clinical trials and some eligibility, but we also need to think more broadly. Last thing I will say is, when we implement clinical trials, we have to be careful that we implement them broadly and around the world. We also have to think about other types of clinical trials. For example, of Orville, you make me think about what can we do for clinical trials to promote people to have good diet and physical activity. 40% of all cancers in the United States, and this is a growing figure in Asia and Africa, are actually due to consumption of too many calories, not enough exercise, and smoking. Clinical trials on how to promote healthful behavior might prevent us from the need to actually treat and cure some of these cancers. Now, I've talked about risk reduction. I do want to end by saying I'm very much in favor of clinical trials to find better ways to understand cancer and to treat cancer once we have it. I'll stop at that point.
I really love your perspective on how we think about diversity and how we achieve equity. And I think the earlier panel made that comment that, the contrast between looking at people's external self and what they're really presenting internally is more important, and really turns our head on the way we're thinking about achieving equality and serving different communities. But I want to get back to some of our earlier discussions about the barriers to patient centricity, why patients aren't coming on trials. And we sometimes think about this as an issue of patient education, but our earlier panel also talked about it was an issue of provider readiness or infrastructure. So I want to ask our panel before we go to questions in a few minutes, when you think about patient centricity from both sides of the coin, the perspective of the patients and the provider trying to serve our patients, what's missing and what's needed, and what would be most important to move the needle to get to that global equity through patient-centric trials. So Terry, I'm going to go to you first. What do we need?
Oh, that's a big question. I think the first thing that you need to even start with is patients don't know what clinical trials are. And it's terrifying to even think back to how little I knew before all of this and what I thought a clinical trial was, and it really is so different than what it is. And then once you kind of get through that fear, and that's, I think, one of the reasons why you've got 95% of people are not doing it. And if we're completely terrified of it, but how are we going to learn about it? Well, I'm going to turn to my doctor. My doctor's not telling me about it. And if my doctor does tell me about something, how am I going to access it? And it's not necessarily getting there and parking, it's childcare. It's like all the living with the side effects and what have you. And so recognizing those are many of the issues, and that it's not going to be a one-stop shop for a worldwide solution. I think that's kind of a lot of it, right? I have not personally gone through a clinical trial. I have many of the people that are in the KRAS kickers, whatever, they're driving, they're flying, they're skipping treatments because they can't get to an outer coastal part of Spain, or they're flying, or they're being forced to fly from Florida to New York or Boston or something just for blood tests every 3 weeks. That's all in design. That's completely fixable. There's not any information given as far as guidance, as far as we have a huge liver toxicities. There's got to be something to air quality and eating and behavior and all these other sorts of things. And we're not giving any guidance with it, let alone just kind of the mental, emotional, how do I wrap my head around the fact that I'm facing my own mortality?
Dr. Powell, when you hear this, how would you respond to the patient who has these concerns? Like, what do you see? What is your vision to see through to get to this better place that Terry's describing?
Well, I think if I take both of your stories, I think they're both examples of, knowledge of ROS1 or KRAS and the mutations needs to become mainstream. It shouldn't be a sort of academic diversion. And I think, cancer trials need to move much more towards being aligned to the precise tumor type rather than the bucket of breast cancer or the bucket of lung cancer. I mean, I think we all know that we get, just like with Luis's trial for the small but highly relevant subtype of MSI high colorectal cancer, where the immunotherapy was a home run. There are a lot more home runs out there, I think, if we get the right matching. So, for example, let's pick an example, triple negative breast cancer. You walk through the door today, big problem worldwide, enriched in African American populations, big challenge because we don't have great treatments. Right now, the standard of care has become what I would call, and I hope this is no insult to anybody who worked on the original trial, Keynote 522, which is really an old-fashioned blunderbuss trial of 4 chemotherapeutics combined with immunotherapy. I mean, talk about kitchen sink. That is the ultimate kitchen sink, and it gave you, what, 12% improvement in PathCR. We don't even know what it does on disease-free or overall survival yet. So we need to go from that approach to saying, you know, how can we break these down into meaningful categories that can address in clinical trials? And I think there's so many opportunities. For example, in triple-negative breast cancer, we know about 40 to 50% of them are, my favorite topic, homologous recombination repair defective. That group of cancers have got very specific treatments. We know that now, right? Take the Larry Norton, we know that there are specific treatments, but the general oncology community just isn't up there yet. So we've got to just accelerate the conversation so that doctors and patients are all saying, you know, what's my precise type, right? I think that's the takeaway. You've got to think, what's my precise type of cancer, and do we have something to address it?
I think that's, Terry, what you talked about as well, is you want to be defined by what you have, not by what you're not. You know, we can't treat what we can't target. I think that's an excellent point.
You know, I think, just speaking as a consumer of trials, there is a point as cancer progresses where some standard therapy wears out and you have to head into trial land. It is a very bewildering world to have to confront. Even if you have an excellent, sophisticated research hospital at your beck and call, you can't just call people up. Trials are all over the country, all over the world. They don't have the trial that may suit you in your region. So I think that is something that really needs some attention. It's easy to get lost, and trials are fast-moving trains. The tableau is changing all the time.
I've got so much to say. Except my mic doesn't work. Can you hear me? Okay. I've got so much to say. I think on top of everyone's great comments, there's financial toxicity, right? The cost of a patient or a caregiver and a caregiver often going to a clinical trial site, parking at the hospital. I don't know about America, but in Australia, it's expensive to park at the hospital, taking time off work.
Come to Memorial Sloan Kettering.
I think it's a common global issue. Yeah, just you know, the cost of taking time off work, organising childcare in my case. There's a lot of cost involved, not just financial, although financial is a huge cost. But we would, you know, like I said, when you do anything for your life, so you would just do it, only because I'm aware that clinical trial is my best chance, but not many people do know that. So if we look at a funnel, right, I'm educated, so I understand about clinical trials and I understand how I can be a beneficiary. I might be a beneficiary of clinical trial. A lot of people don't have that education. They don't have the money to be able to afford joining a clinical trial. They're not. So that's the patient side. From the provider's side, the design of clinical trials, the eligibility criteria, how generalizable is it? I think you mentioned that before. How generalizable are the eligibility criteria? If it's a lung cancer trial and you can't join a trial if you're over 70, I don't know that that's the case anymore, but, you know, or brain metastasis, often that's an exclusion. But how do we know, like so many lung cancer patients do have brain mets, but they're not allowed to join a trial. There are a lot of barriers. I think ultimately the answer, and I think that's where we wanted to get to, is, you know, inclusion of the patient and caregiver's voice in the design of clinical trial is essential. If we're talking about inequity of today, it's because we haven't been engaging with the smaller voices of our community. We're in a place where there are gaps because we're not involving the underserved community in the design of health services and research. So it's important that in the design of clinical trials, we need to talk to not just people like myself or Terry or, you know, any of us who can speak up, but also engage a diverse community of advocates. And we need to train those advocates to understand science and not just say, look, you're just a patient, you have no idea. Well, educate them. The International Association for the Study of Lung Cancer runs a really great program called the STARS program, where advocates like Terry and myself, we were educated through that program, and we can support each other. So it's about patient inclusion in clinical trial designs, but also empowering patients to do that.
Last word, Dr. Brawley.
Yeah, in the 1990s, when he was at the NIH, Zeke Emanuel, who's now at the University of Pennsylvania, did a series of studies looking at the dynamics of accrual of clinical trials. In the United States, a large number of cancer patients don't have a clinical trial available to them in the hospital or the clinical setting in which they're being treated. When they have that trial available and they are eligible for it and offered it, 70% of people, be they black, white, rich, poor, or other, say yes. The problem is we need to have good ideas that are translated into clinical trials, and then we need to have those clinical trials available to the doctors and patients. Now, I can't speak to Australia the way you can't speak to finances in the United States, but I can tell you, especially having been chief of service at a large hospital, sometimes you just can't afford to start a clinical trial in your hospital. Sometimes actually starting a clinical trial in your hospital is actually going to worsen the quality of care for everybody in the hospital because it's going to tie up the CT scanner longer and make the line for the CT scanner longer. It's going to tie up the pharmacists and distract the pharmacists away from their regular work, and it's going to cause some mistakes in terms of filling of prescriptions and so forth, preparing of chemotherapy. We're here on the Upper East Side of New York, and we have a certain degree of economic prosperity and comfort here. But there's a lot of places, even in the United States, that you just cannot afford to implement clinical trials, even though you would like to, if you're the doctor or the chief of service at that hospital. I wish there were more ways of paying for those clinical trials. And by the way, there are a couple of different kinds of clinical trials. In the United States, we have corporate-sponsored clinical trials. We have NIH-sponsored clinical trials. The NIH-sponsored trials are more designed to try to learn a little bit more about a particular disease or how to treat a particular disease. The corporate trials are more designed to get that specific drug approved. So there's a little bit of difference there. I tend to prefer the NIH form of trial versus the corporate. But in any event, we need to figure out how we're going to pay for all of this. And part of the democratization or getting clinical trials to everybody is how we're going to pay for all of this.
Do you think there's a role in collaboration in minimizing the cost, because so much of the cost is actually duplicated for no reason, really, if people would just collaborate more?
The collaboration savings is when you have a drug or you have a treatment and you actually want to get approval from governmental agencies. The sharing of the information from various countries or even within the United States, various regions of the United States, that can lead to tremendous cost saving.
It's an excellent question and a really good argument for international collaboration. Not only we heard the data about the number of people in between the US and China that we can learn from, and that learning that can be applied to everybody in the world, but also the cost sharing of working together on that shared data, all for the benefit of patients. I think we heard today that patients will tell you what their barriers are and give you the solutions, but the system also needs to be adjusted to be ready to receive and treat these patients who want to come into clinical trials. So I think it's working at the issue both ways. Before we go to questions, I want to give the last word to Lillian. I can feel you leaning in.
Great reading of body language. No, I was going to say, in the panel previously, I can't remember who it was, but that mentioned about real-world data and the use of real-world evidence. And I'm just you know, I think that's a really, really important area that we need to pay more attention to, because that's an area where patient centricity can come into, you know, gathering evidence, to make change.
That would have been much better than you being on a flight for an hour to go to every meeting at the Cancer Center, right? So something we should think about as well. Oh, thank you. Oh, and I have just been told that we have no time for Q&A because I let them talk for way too long. So the good news is our esteemed panelists will will be out at the next coffee break or lunch. So if you have any questions, I'm sure they'll be willing to chat. So my apologies to the audience for going over. And I want to thank everyone for coming and sharing their stories and giving the patient perspective.